All right. Good morning once again. Of course, as often happens after breaks, it's so hard to get everyone back in, but we're about 15 minutes behind schedule. So we'll just start with the next session, or basically closing the opening ceremony, which we switched it around a little bit because of the schedule of the VC. So I'm going to introduce our first keynote speaker for the conference. We evaluate the vaccine capacity in Cuba. And I just thought that she has a lot of lessons that she can come and share with us. And I'll try and summarize the background a little bit. So Dr. Ngozi Erondu is a trained infectious disease specialist, an epidemiologist, and also a health system policy and global health governance expert. Her research has focused on strengthening disease surveillance and health systems and improving data for resource allocation decision-making in low and middle-income countries. Currently, she examines regional leadership in pandemic preparedness and health security governance across sub-Saharan Africa, the Middle East, and Southeast Asia. Her support is aimed at strengthening institutional capacity to control infectious diseases such as COVID-19, Ebola, meningitis, malaria, and poliomyelitis. She's also served in an advisory capacity on the Global Preparedness Monitoring Board, Africa CDC, and the UK government all-party parliamentary group on global health. And through her thought leadership and circular activism, she champions shifting power in global North-South partnerships. And this has led her to be a co-chair of the O'Neill Institute, Lancet founding O'Neill Institute at Lancet, and a founding member of the Decolonization of Global Health alumni group at London School of Hygiene and Tropical Medicine, where she got her PhD MD, PhD, and where she's also an assistant professor. She's given lectures at over 60 universities around the world, and she's currently the technical director of the Global Institute for Disease Elimination. She's also a senior scholar at the O'Neill Institute at Georgetown Law University and an associate fellow at Chapman House. She's also an alumni of the Aspen Institute New Voices Fellowship and the Johns Hopkins University for Emerging Leaders in Biosecurity program. And she's also a co-editor of the Health Security section for PLOS Global Health. There's more to go, but I'll leave it here and I'll leave you to read in the brochure. So without much ado, I would like to ask you to help me welcome our first keynote for the WACCBIP 2023 conference, Dr. Ngozi Erondu.
Thank you so much, Professor Kwashi, and good morning, everybody. Okay. I first want to give my humble appreciation and thanks to Director Gordon Amondare and Professor Kwashi for the kind of invitation to come and speak to you all today. I also want to say thank you to the organizers, faculty, and students for participating in this conference. I'm so excited to be here. It's my first time in Ghana, even though I'm Nigerian. This is my first time coming here. And I really want to congratulate you as you enter your 10th year of research excellence. I have to say that your commitment to excellence is really palpable. When I was looking at the brochure for the conference, I was impressed. There were, I think, over 90 posters that are being featured throughout these 3 days. And I would say that it's an honor to be here, but it's also a bit of a surprise to be invited as a keynote speaker because as an epidemiologist, I'm usually on the other side of the science that you all do. So I send the sample to you, you genetically link the case, and then I go out and continue outbreak investigation or immunization campaign. So that's usually as much engagement and interaction I have with laboratory folks. But I do want to kind of talk a little bit about my career and how it came to me focusing a lot on policy, which is what I want to talk to you today about. So I started as a field epidemiologist 14 years ago. As a Nigerian American, I remember throughout university just trying to see how I could come back and work in Africa. I was blessed to start at the US CDC in Atlanta, and one of my first global health assignments was with 4 other Nigerians in Kenya supporting active case surveillance for polio and immunization activities, amongst other things. I remember being so excited and preparing for the assignment by reading the reports from the teams over the past 7 years before me. And while we were there to strengthen surveillance, support microplanning and immunization campaign activities, as well as identify needs for the lab transport system, for some reason, all the recommendations that I was reading were about preventing staff turnover by providing higher pay, better transport for clinicians in rural postings, ensuring enough commodities for taking samples of all the notifiable diseases, not just polio. The reports spoke about clinics that hadn't had running water in years, areas where the infrastructure was crumbling, and other issues that were vital for anyone to do. And finally, I noticed that in the reports from the previous 7 years, the recommendations were all the same. And then eventually I too would write very similar recommendations. After speaking with many of the colleagues in the clinics at the Ministry of Health in Kenya, I realized that this is because programmatic change often does without implementation is really just politics. Workers, which are the same people that we ask. I know you guys are probably just looking at me there, but just have to listen to me. So just so you know. Our countries outside of the West, they call it global, the work in these countries. I learned that research communities are public health order. But I call proximate design and delivery of public health by local experts and professionals. It's not as catchy as localization, but I think it's clearer. To dive really deeply into innovative cutting-edge research being done at this center, before in Africa and globally. And one important in Africa, how we produce science to directly influence local and regional policies, and 3, building a research ecosystem that we want and need in Africa. Peter, I'll just ask you to let me know when I have like 5. This continent come from multilateral institutions of excellence who were introduced earlier. You should all be proud that with the initial investment from the World Bank, you've been able to multiply that not only through resources, but also a near decade of new talent and strong research. But I want to remind us that the status quo for decades in global health is that the global north leads the research priorities. And I believe, and I know that others here too believe, that public health should first benefit the proximate public and then the global public. So what does all this mean for African science solving African issues? When we do not set the agenda to include African health priorities, then those priorities will be ignored. Let's illustrate this with a case study that I think you're all aware of. The first human case of monkeypox, now known as Mpox, was identified in DRC in 1970. And since then, there's been a lot of smaller outbreaks, mostly in rural areas in West Africa. Now, there was a small outbreak in 2003 in the US due to imported animals from Ghana, but in 2017, that was a small outbreak. It affected about 40 people in the US. But in 2017, Nigeria had the largest outbreak, which 200 confirmed cases of Mpox and 500 suspected cases. A good colleague of mine, Dr. Adeshola Agunleyi, she characterized the outbreak in a Lancet article and noted that there was potentially human-to-human transmission. Now, Nigeria's CDC did great work on this study, but it also noted its limitations, which included that they were only able to do genomic analysis on seven samples, and they were not able to get any samples from animal reservoirs. Still, from that study, monkeypox was included as a priority disease in Nigeria. Now, we all know that last year, Mpox outbreaks infected thousands globally, including in European countries, Canada, and the US. In those outbreaks, there were vaccines used to combat Mpox. And like we saw in COVID-19, African countries received limited quantities of vaccines in a delayed time frame. So even though the global outbreak peaked in July, the first vaccines to use in an Mpox outbreak response in Africa were received on the continent in December 2022. And this was a donation from the Korean government. But what if in 2017 there were regional negotiations with pharma and a domestic, and even better, a campaign to protect healthcare workers in high-risk areas with those vaccines? What if a regional declaration of Mpox as a public health emergency of intercontinental concern would have resulted in a concerted effort to advance science of the disease and understand the dynamics of human-to-human transmission? This could potentially have led to either preventing or being better prepared for the 2022 epidemic. HIV, meningitis, and deeply problematic for science and health. On a global level, it will all tropical medicine and its tacit hierarchy of human worth based on geography. Also, in the light of changing geopolitics and increased regional associations and institutions, there is a need for regional policy-aligned science agenda setting. Additionally, there are new global health actors coming into the global health space, especially in the private sector, national public health institutions, but also regional institutions like WAHO and Africa CDC. And I know that there is a community localization plan at WACCBIP. When there are regional initiatives and plans, like for the Partnership for Portfolios, but also the education and human resource pipeline, there are great examples of this during the COVID-19 response. Institutions like WACCBIP readily provided the genome sequencing data to inform outbreak response efforts of regional and national public health teams. Now, this must continue. There's a lot of value in a regional bloc, and we're seeing this when we look at the negotiations with the pandemic treaty at the global governance level, but also the efforts for local manufacturing in Africa. And there's also a certain level of inter-regional peer pressure that can really help advocate for country-by-country political commitment to all types of public health to solving all types of public health problems, from research and development coordination to improving supply chains to identifying a regional plan towards training health and science professionals to meet the needs of, even though it is like a lower in capacity and their science workforce. It was really impressive. Money matters, but money without people means empty hospitals and unused lab equipment. And in my experience, generation of science students have been trained here in under 10 years. Are there more? Sorry? 2 master's students. Well done. But there's more needed to keep these brilliant people here, not just at WACCBIP, but in Ghana or else. I think the global health created an important opportunity in our field. Since many global health funders are from countries, and it's not ubiquitous, but there is awareness that it's not okay to invite scientists who are experts and leaders in their own right onto a research project that has already been developed. And usually this is done to maybe tick a box for like a grant application. Equitable partnerships provide an opportunity to ensure that the gaps in the health of local communities can be addressed by local science and local research. It's the responsibility of all of us who are dedicated to research for real impact to push for African-led policies. Well, for years I've been inspired by Dr. Oyewale Tomori, the Nigerian virologist that I think a lot of you know. They're a geneticist from Nigeria and who works on resistance to malaria. And she is an avid WACCBIP supporter, just to let you know. As well as Dr. Fredros Okumu, a Kenya parasitologist and entomologist who is also the director of science at Ifakara Institute in Tanzania. Now, together with Drs. Ifi and Fredros and 3 other African scientists, we wrote an open letter in Nature, where we drew the attention to a substantial grant that was awarded to a prominent international, it was a data for decision-making project for malaria and in countries. We pointed out in that paper that in 2017, the USA, UK, and Canada collectively spent $1.1 billion on malaria development aid, which includes research funding. And we found that 81% of that funding was used to support institutions in the funding countries. So 81% of that, of the funds that came, but likely a lot of these were also in high-income countries, which leaves about 1% of malaria funding available money. I think global health and geopolitics is very big. It's soft power. There's talking about the need to make this more equitable. Now, this example that we wrote about in Nature, it reflects how funding structures create an imbalance of power and a monopoly that favors Western institutions. And this is derived in part from the perpetuation of inequalities in access to funding with policies that lock out Africa, help guide their new strategy. Then Dr. Raj Punjabi was the global coordinator for PMI. And we stressed to him the need for PMI and similar funders to map research institutions across Africa. We were trying to say there are people and experts on the continent that could use this money directly rather than going through or channeling it through non-endemic countries to do this work. At that time, I didn't know about WACCBIP, but this is the type of information that I would want them to include in that type of mapping exercise. For this case, PMI was quite receptive. My co-authors and I were surprised to see that nearly all of our recommendations were included in their new strategy. It wasn't just the letter that made it impossible for this change to happen. It was years of scholarly activism and policy engagement, from people like Dr. Tamori as well as other scientists. And that's why I think that scholarly activism and engaging with policymakers and research for policy influence is not an extracurricular activity for scientists. I think it's essential and it's a part of our work. So far, I've been talking a lot about researchers to have an influence on what I call big P policy in global health, whether that's ensuring alignment between national and regional research agendas, or scholarly activism to guide funding and delivery methods. And I know some of you, especially the early career researchers, may be thinking, okay, I have to do my research, I have to publish, and I have to understand how and where policy is made. It's just as important for us to influence small p policy change. A lot of this happens within your collaborations and while you're writing new grant proposals. It's important to be aware and to thoughtfully critique partnerships that do not explicitly state who has ownership of data, research cohorts, and samples. When shaping research questions, it's worth engaging in dialogue with funders and partner researchers and working out a way to shape the question in a way that will benefit your local issues and stated research priorities. One thing that I've noticed is that funders often do not consult the recipients of grants when they're doing major changes of how they do grant funding. For example, I spoke at a welcome meeting earlier this year, inclusive, and they created like a large accessing research funding for a Black Briton or a Black American is different than someone searching for research opportunities for sub-Saharan Africa. And so I was these issues, especially when we have good relationships with our partners and we feel comfortable to do so. Finally, if everyone that's trained here stays in academia or goes to the Ministry of Health or the the Ghana Health Service or other, very academic or health-specific sectors, then it will be much more difficult to communicate across sectors, especially as we see more multi-sector challenges. Of course, the pandemic was one of those things, but right now, I'm sure you all have heard of this syndemic, these multiple, issues that are happening at the same time, whether it's climate change or One Health or pandemics or non-communicable diseases. So that's in health, but even beyond that, there is value of, of working in private and public entities, including technology startups, finance, even infrastructure development. How much easier would it be if we had someone working in, let's say, the Ministry of the Interior? If we had someone working there that was trained at WACCBIP, it would be much easier to advocate for more roads to clinics or to reference laboratories. So it's something to think about. Now, everything that I've been discussing cannot and will not happen and will not be possible without consistent domestic investments in the national and regional research ecosystem. WACCBIP illustrates what is possible in terms of building world-class scientific capacity. But WACCBIP and the University of Ghana and the Noguchi Institute, these are not bubbles. They exist in a larger context. And success as far as advancing science and ensuring that there's strong research capacity, thank you, is linked to how Ghana and other African countries prioritize science moving forward. And this brings me to my final point of today's talk. How do we create the research ecosystem that we want and we need in Africa? Just gonna go a bit fast through this. Just to say that currently the average funding of research from countries in Africa is 4-fold lower than the global average of like domestic product invested in research. Now, this keeps African researchers vulnerable, and African research vulnerable to the political environment of other countries because there could be cuts to research. We saw this with neglected tropical diseases. When the UK pulled out its funding, that left a huge funding gap of £120 million across 23 countries, affecting millions of people across Africa, and there was no alternative funding. Researchers do have a part to play in holding governments accountable to domestic funding of research, but also to higher education and training to produce world-class researchers. Beyond, ensuring that research is part of ministry budgets, they should also prioritize research and development as a pillar of development and health security. I just want to say, it would be quite self-defeating to have so much investment and focus on young and early researchers at WACCBIP just to lose them, to UK, US, other countries due to brain drain because they're not remunerated the way they should be, or that there's not enough infrastructure. And maybe Ghana doesn't have the same issues as all the other countries, but this is something that is quite pervasive across Africa. In addition to the African Centers for Excellence initiative, there's the Pan-African University, African Research Universities Alliance, Coalition for African Research and Innovation, Alliance for Accelerating Excellence in Science in Africa, and the consortium also must be embedded in what we do. I spoke to a few scientists in preparation of this talk, and they all credit, while this is excellent and admirable, unless mentorship becomes a major, continental priorities are put first. I think I'll stop there. Thank you for, okay, if you have any questions, please go ahead.
So we have 10 minutes for questions.
Thank you for a nice talk. I was expecting slides, but I think it made us listen more. My question is about your last point on mentorship. I'm very particular about mentoring young people, and I'm also privileged to have been mentored by people like Prof. Wandari and others while being in WACCBIP. And so my question is, what ways do you think this can be achieved? Because clearly this is not happening in other institutions, and you find colleagues in other research centers who are always complaining they don't get enough support, they don't get enough help, and so they are looking for greener pastures outside. And then they get there, and then there are other difficulties, so they want to come back, but then they're kind of divided. So what ways do you think we might improve on our mentorship program?
I guess I'll take a few questions and then answer them.
You mentioned this in the earlier part of your speech about the continent. Where I just did some research and innovation levy, and how.
Yeah. Thank you for this and adequate payments. I'm wondering.
I'm sorry, I'm having a little, I don't want you to take off your mask, but I'm having trouble hearing you a little bit. I'm sorry. Okay.
Oh, sure.
Thank you.
Oh, is it better? Okay.
Yeah, it's better, yeah.
Sure. Yeah, you talked about a lot of salaries and adequate payments, which is important, definitely. But what is also important in our job, and I guess you agree, in research, and it means always a lot of overnight hours, and you chronically feel underpaid there. but I see there's a conflict of interest. Now, if the salaries are too high, and it's pretty much everywhere, especially at the junior level, you kind of go in there for the wrong reasons, and that's not for the research, but for the money. And that is where I always see a big potential.
There was personalities that, motivated to support your career. There were like specific